approach to antenatal hydronephrosis. So are you starting, Bernard?
It wasn't the plan, but my colleague is running a bit late, so
no, that's absolutely fine. It really doesn't matter. Thanks a lot for being ready. So Bernard Murray will be discussing congenital obstructive posterior urethral membrane. Yeah, I think you can start if you're ready. Thanks a lot.
Sure. Thank you, Sam. Good morning, everyone. Like as mentioned, I'll be trying to give a brief enough overview of the topic of posterior urethral valves or COPEM, and I've got the challenge to try and do this, and I'll try and stick within the allotted time, although it might be a bit of a challenge, so bear with me. Just as a background, Giovanni Morgagni was the first to describe the congenital obstruction of the posterior urethra ascribed to valve-like leaflets in the 1700s. And this was confirmed by Langenbeck early in the 1800s, both by post-mortem sections. Tolmaciu in 1870s, first to kind of recognize it as a pathological entity and give a theory as to its embryology. And in 1919, Hugh Hampton Young, while publishing his landmark paper, described the first endoscopic diagnosis as well as classification, in which he termed the posterior urethral valves, and it's a classification that's still widely used today. A year later, Alexander Randall carried out the first endoscopic resection of valves, and he gives a description that remarkably encapsulates what we see even today, where he said the prostatic urethra is markedly dilated, the vesical neck is raised, the bladder orifice relaxed, deep fittings penetrate down into either lateral wall of the prostatic urethra, and at the extremity of the verumontanum is seen a fine frenulum which extends distally for about 1 centimeter, and in dividing forms what is apparently a definite valve on either side of the urethra rising from the floor to each side wall. Posterior urethral valve is one of the few life-threatening congenital anomalies of the urinary tract during the neonatal period, and is cited as the most common cause of bladder outlet obstruction in the pediatric population. And it's this bladder outlet obstruction at a critical time of organogenesis that may produce profound and lifelong effects on bladder and renal function. The risk for chronic kidney disease has been quoted to be around 32%, and about 20 for end-stage renal disease, although this is higher depending on where you read. Conversely, 70% of pediatric end-stage kidney disease can be attributed to posterior urethral valves. And even though an incidence of 1 in 7 to 8,000 live births has been estimated, some we know rather well have once said that it should read posterior urethral valves are not rare, they are just rarely identified. I think the economic repercussions in terms of dialysis and renal transplantation arising from this is enormous and can't be underestimated. So what are posterior urethral valves? Well, going back to what Morgagni said, a congenital obstruction of the posterior urethra that's ascribed to valve-like leaflets. Now, Vilpot in 1832 coined the term valves because it looked quite similar to cardiac valve when viewed as post-mortem during post-mortem dissections. Certain other authors also use the term valve almost as a functional description, where a catheter is allowed to pass in one direction, but urine is not allowed to flow in the other. To understand valves, you've got to have a look at the embryology. And so the cloaca separates into the urogenital sinus and a rectal canal sometime between the 4th and 6th weeks of gestation, and the urogenital sinus gives rise to the bladder and the posterior urethra. At the same time, the Wolffian ducts or the mesonephric ducts fuse with the cloaca, and it's theorized that the abnormal insertion and migration of these of the orifice of the mesonephric duct is what causes valve. So when the insertion of the mesonephric duct into the cloaca is anomalous or too far anterior, normal migration of the ducts is impeded, and the ducts fuse anteriorly, resulting in the formation of these abnormal tissue ridges, which are termed the posterior urethral valves or the obstructing membranes. Now, I'm not going to go through all these theories just in the interest of time, but theories behind the embryological origin is rich with controversy, keen scientific observation, and methodical investigation spanning almost 200 years of literary publication. And despite this, there's still a rather big debate of its embryological origin. So the damage caused by valves not only is limited to, well, doesn't only involve the urinary tract, but lung hyperplasia develops because of oligohydramnios, as normal amniotic fluid levels are required for the canalicular phase of lung development, which occurs between about 16 to 28 weeks of gestation. And one cause of the oligohydramnios obviously is the bladder outlet obstruction in the fetus. There can be reversible renal injury or renal damage due to obstructive uropathy, as well as irreversible renal damage due to inherent renal dysplasia, as well as tubular damage that might lead to a sort of nephrogenic diabetes insipidus. The bladder might, the changes might lead to poor sensation in the bladder, hypercontractility and low compliance, and an eventual myogenic failure that might result in incontinence and poor emptying. And the ureters might suffer from poor contractility and an inability to coapt and transport urine. I think the valve bladder is an important concept to mention, as this term was coined by Mike Mitchell in 1982 after he reviewed 11 patients with worsening renal function and hydronephrosis, even though there was no evidence of residual bladder outlet obstruction. The term valve bladder syndrome is essentially a pathophysiological process where the underlying obstruction initiates cyclical events leading to eventual bladder decompensation, and really describes a continuum of symptoms of bladder dysfunction. Urodynamics is important in monitoring these patients, as they might evolve through sort of 3 distinct phases of bladder changes, starting with the true hyperreflexia in infancy and early childhood, decreased intravesical pressure and improved compliance, improved bladder compliance in later childhood, and an increased capacity bladder with hypocontractility and atony with a risk of myogenic failure in adolescence. So the valve bladder sort of evolves from due to this partial bladder outlet obstruction. The bladder compensates by becoming mildly hypertrophic and trying to, which might lead to increased voiding pressures because the bladder is trying to preserve near complete emptying. Due to this ongoing hypertrophy, there's bladder wall remodeling, which leads to collagen deposition and hypoxia, which further leads to a decreased compliance, increased post-void residual and elevated storage pressures. And that leads to an increase, or the storage pressures then gets transmitted to the upper tract, which leads to increase the renal tubular damage. We end up with kidneys that can't concentrate, as well as polyuria. The bladder will then continue to attempt to void at high voiding pressures. And it's never really in rest, because as soon as the bladder empties, the urine stored in the hydronephrotic kidneys immediately empties. And that kind of just contributes to a higher PVR, and so the cycle kind of continues. VRD syndrome, or valves unilateral reflux and renal dysplasia, is also important to know. This is a commonly observed association with valves where there's unilateral high-grade reflux into a dysplastic kidney, but with a relatively normal contralateral unit where the renal function is preserved. Now, the hypothesis is that this is sort of a pop-off mechanism or a pressure reservoir. Essentially, one unit is taking one for the team, if you will, trying to mitigate and protect the contralateral unit. So theoretically, one should have a better long-term renal prognosis. However, long-term studies doesn't prove this to be true. So Coco in 97 show that even though 67% of patients with valves had a normal creatinine of 1 to 2 years of age, about 30% of them, well, only 30% of them had a normal creatinine at the age of 8 to 10. And he just warned that VRD syndrome might actually give a false sense of security, and they would still require a relatively close follow-up. The classification of young is still widely used today, as I mentioned earlier. He classified 3 types of valves with a relatively complex sub-classification I'm going to leave out for now. But type 1 valves, by far the most common, is essentially arises from the verumontanum, courses anteriorly and then fuse in the midline. Type 2 valves, debate whether they really exist, but they basically extend from the vero posteriorly towards the bladder neck and not really regarding as clinically significant as they're non-obstructing. Type 3 is described as an annular ring that attaches to the entire surface of the urethra and with a small opening in the center. These are just endoscopic images of both type 1 and type 3 valves that Young had described, where the outline or the margins of the valves are well demonstrated. However, in the early 90s, Professor Dewan kind of challenged Young's nomenclature and postulated that this is probably not correct. They felt that the obstruction is due to a single membrane, and error in the section techniques of the early postmortem studies is probably the reason why, as the membrane was essentially cut in half and appeared to be two valvular structures. It also said that type 1 and type 3 valves is essentially the same thing and not two processes, and it was mistaken for one another during cystoscopy due to different angles and flows, as well as prior instrumentations. And I believe that there's actually only two distinct entities with two distinct embryological origins, namely copum or congenital obstructing posterior urethral membrane that essentially arises from a Wolffian duct issue, as mentioned earlier, or what is called Cobb's collars, which results as the persistence of a urogenital membrane. They further mention issues with Young's findings, as Professor Dewan did an extensive literature review of Young's work. And it's interesting to note that there are quite a few cases where the valves were only diagnosed by finger palpation via antegrade cystotomy. And only 3 of his series had actually had cystoscopy, but they were aged 17, 26, and 42, of which one had prior venereal disease. And even though these were the standard methods back in the day, it certainly make accurate anatomical and embryological description a bit difficult. So this Douglas Stevens, also in a sort of mid-90s, described quite a detailed explanation of valves in terms of the embryological origin, and this is relatively in line with what Professor Dewan also said, where type 1 valves, or copum, if you will, is due to a abnormal Wolffian duct. It's a sort of an oblique membrane and it's continuous to the verumontanum. And type 3, or Cobb's collars, is a transverse membrane with no continuity with the verumontanum, and it's due to the persistence of a urogenital membrane. In terms of antenatal diagnosis, generally in the developed world, about 40 to 50% are diagnosed by prenatal ultrasound screenings. And the important findings is that of a thickened, dilated bladder, bilateral hydroureteral nephrosis, oligo or even anhydramnios, and the severely dilated posterior urethra, or the so-called keyhole sign. Just to note that these are not specific to posterior urethral valves, but just indicate severe lower urinary tract obstruction, as the sensitivity for valves is about 94%, but the specificity is only about 43%. And obviously, these all need to be sort of present in the male fetus, as it's an entity only in male infants. Ultrasonography antenatally might struggle to differentiate between different causes of obstruction, as mentioned, and the findings of lower urinary tract obstruction in prenatal ultrasound in a male infant should necessitate early postnatal ultrasound and avoiding cystourethrogram, as also recommended there in the little sort of yellow block by the EIU. Generally, ultrasound is adequate in 90% of cases to assess the urinary tract, but there can be issues where there might be poor technical conditions such as oligohydramnios or anhydramnios, or a large maternal body habitus, in which case one might require fetal MRI, as this might give additional information due to superior anatomic details, and it might better assess the urethral as well as the posterior urethral dilatation without being significantly affected by the amniotic fluid volume or the fetal position. It might also give good information regarding lung hyperplasia and cystic renal or dysplastic renal changes. Pico et al. Reported that fetal MRI findings coincided with postnatal diagnosis in about 70% of cases, whereas ultrasound only did so in about 56%. Postnatally, ultrasonography is important, but the findings will be rather similar to those done antenatally. And it really is the voiding sister urethrogram that is the definitive radiological study to confirm the valves, as the lower urinary tract is well outlined during the voiding phase. Obviously, this is done once a patient has been stabilized and is usually done catheter-free, so that it can offer unobstructed views and that it won't give a false impression of a dilated posterior urethra. So one can, on a VCUG, expect to find a thickened bladder, trabeculated bladder diverticuli, high-grade vesico-ureteric reflux is present in about 50% of cases. A hypertrophied elevated bladder neck can be seen on the voiding phase. And the grossly dilated posterior urethra with a caliber change at the junction of the anterior urethra can be seen. And of course, the transverse membrane or cusp, the sort of semi-filling defects that would indicate valves is often seen. Radionuclide renal scans used to quantify split differential renal function. And in the case of urinary tract obstruction, the MAG3 is preferred. Serum creatinine, urine electrolytes is useful as trends are monitored to deduce effective renal function, and values at 1, 6, and 12 months is used to evaluate the response to treatment in the neonatal period. It's just important to note that early tests before the 48 hours is likely to reflect maternal values, its true fetal values, and it kind of can be apparent after sort of 48 hours. Prenatally, valves are suspected on ultrasound before 24 weeks. It's associated with the increased perinatal mortality, and oligohydramnios in the second trimester is associated with a perinatal mortality of over 90%. Postnatally, about half of patients will present with a urinary tract infection, although neonates can present with respiratory distress due to lung hypoplasia, as mentioned earlier, as well as abdominal distension due to a overfilled bladder and poor urinary stream. Infants might strain or grunt while they void. They might have a poor urinary stream or present with urosepsis, as well as failure to thrive, as depicted on the picture on the right-hand side. That is from the SMJ in the 1970s, depicting the boy on the left-hand side with valves and the one on the right-hand side. They're both 2 years old. The one on the right-hand side without valves, although I'm not sure why he has a cast on his right leg. Older boys might present with urinary tract infections, frequently straining and poor stream, as well as day or nighttime incontinence. So just a short note on antenatal intervention, as my fellow speaker will also briefly mention it, that untreated severe low urinary tract obstruction is associated with a perinatal mortality of about 45%. And as you know, risk of end-stage renal disease is relatively high, and it's these devastating consequences that have sort of driven enthusiasm in antenatal intervention. The aim is to restore normal amniotic fluid volume to try and prevent further pulmonary hyperplasia or renal damage. Just to note that there is a significant fetal and maternal morbidity, so patient selection is crucial. The question is always who should undergo antenatal intervention. Historically, it was for patients with signs of low urinary tract obstruction, but with a normal karyotype and no signs of renal dysplasia on ultrasound, with favorable fetal urine biomarkers, which I'm not going to go into detail now. But the Society of Fetal Urology had a sort of panel discussion, and in an attempt to better define who should qualify for antenatal intervention, came up with a sort of a staging classification or criteria, where patients with stages either stage 1, 2, or 3, where stage 1 was classified as mild obstruction, 2 is severe but with preserved renal function, and 3 is severe obstruction with sort of abnormal renal function. And the patient, it was based on the volume of the amniotic fluid, signs of dysplasia, renal dysplasia, renal damage on ultrasound, and fetal urine biochemistry. And they kind of recommended that fetal intervention be applied only to stage 2, where stage 3, generally fetuses are probably too sick to benefit from it, and in stage 1 they are probably too or not sick enough to benefit from intervention. So they concluded that standardized patient selection utilizing a staging system is definitely the way forward. Antenatally, intervention either by vesicoamniotic shunting or fetoscopic valve ablation as open fetal surgery has kind of been abolished due to minimal invasive techniques. The data has severe limitations, though, as due to small case numbers, significant variability in the criteria for patient selection and non-uniform outcome measures. And thus the EIU currently doesn't recommend shunting antenatally to improve renal outcome. I'm just going to briefly mention the Pluto trial. I know my next speaker will also mention it. But the Pluto trial basically is also a sort of a landmark trial and often quoted. Looked at shunting versus conservative management for fetal urinary tract obstruction, and basically found that although there was a survival benefit of shunting up to sort of 28 days, there was no renal benefit. So there was no long-term renal benefit and no difference in the incidence of end-stage renal disease between the shunting and the conservative groups, and concluded that although there is some observational evidence for perinatal survival, the chance of a newborn surviving with normal renal function is low with or without shunting. So shunting is generally done percutaneously and done ultrasound guided. Very limited and not great quality data regarding fetoscopic valve ablation, and the mortality rate for fetal surgery is quite high, and that's why patient selection is quite important for these interventions. Just to summarize it, like I mentioned, there's some evidence for improved perinatal survival with antenatal intervention, but no strong evidence to benefit or to suggest a benefit to renal and bladder functions. And there's currently no current consensus regarding the ideal timing of these interventions. And studies are limited due to small case series with a heterogeneous patient population, technical modifications between studies making it difficult to generalize these conclusions to the general population. Going to focus a little bit more on postnatal management, where it really centers around stabilizing an infant born with valves, confirming the valves on VCG and bladder drainage as initial management. And then after that, there's sort of 3 important steps or 3 important pillars in the form of valve ablation, plus minus urinary diversion, and bladder management with long-term nephrourological follow-up. And we're going to just stand still at these for a little bit. So in terms of initial management, I mean, a lot of these babies might require respiratory support in the neonatal ICU setting. But from a urological standpoint, the first important step is bladder drainage, usually done by a small feeding tube or urinary catheter, and it's drained transurethral. It's important to note that it's done without a balloon, as the balloon might occlude the ureteric orifices and induce bladder spasms. A angled tip catheter or a stylet might be required if it's difficult to pass due to hypertrophied or elevated bladder neck, and the placement can be confirmed with an ultrasound or even a one-shot cystogram. Further, fluid and electrolyte correction is important, as they might have electrolyte abnormalities such as hyponatremia due to hypoaldosteronism and metabolic acidosis. Prophylactic antibiotics has been recommended due to the high incidence of high-grade viscoureteric reflux. And I think at this point, it's quite important to counsel the family regards to the relatively long journey ahead. The next step would be valve ablation, and it's generally done when, as mentioned, when the child is stabilized and when the valves have been confirmed with postnatal avoiding cyst urethrogram. And the aim is to restore flow through the urethra and kind of restore normal bladder cycling, filling and emptying. Just as a point of interest, historically, it's even sort of been described by Ms. Ines Williams there in the corner, to have been done blindly with a sort of crochet type hook, where the hook was passed retrograde and kind of feeling the hook catch onto the obstructing tissue. That was ablated, I assume, by kind of just pulling on it, which I find rather brave. Luckily, these days we don't have to go through such measures. Generally, valves are ablated at the 5, 7, plus minus the 12 o'clock positions, and we've got quite a few more options other than crochet hook. So a cold knife and various electrosurgical applications can be used, like a Collins knife, a small buckley electrodes, a hook electrode, even holmium or thulium lasers can be used, and they might provide added benefit of controlled valve ablation with a lower risk of urethral stricture due to limited tissue penetration. If the urethral caliber is big enough to accommodate the pediatric resectoscope, a hot loop can be used, and it's also a Fogarty balloon has also been described. It's generally, the choice is generally down to surgeon preference and institutional protocol, as data suggests that the outcomes in terms of the valve ablation is relatively equal in experienced hands, although it seems that the cold knife comes with slightly fewer complications in the form of urethral stricturing, although bleeding might be a bit of an issue with the cold knife. So the top images is just the demonstration of the cold knife incising valves at the 7 o'clock, 5 o'clock, and the 12 o'clock position. Picture E and F is a hot or a hook electrode, and the rest are just illustrations of pediatric hot loop resectoscope and a Buckley electrode. Generally, urinary catheter is left for about 24, sometimes even up to 48 hours post-op, and then literature generally cites that a repeat VCUG is done after a month to assess the adequacy of valve ablation. Although there is emerging literature that a VCUG alone could miss residual tissue, and there are authors that kind of suggest rather doing an interval cystoscopy and reablation at about 6 weeks. And again, to cite Prof. Dewan, he actually demonstrated that about 47% of those who with severe copium required a redo fulguration. In regards to bladder neck incision, it's proposed for those with a high bladder neck or bladder neck hypertrophy. Historically, the fear used to be a risk of incontinence and retrograde ejaculation later in life, although those fears has mostly been refuted by literature. And they seem to be mostly done in selected cases, either concurrently or as a delayed procedure. And there is data to suggest that with bladder neck incision with valve ablation seems to have improved urodynamic and bladder and even possibly renal outcomes. Although I think standard bladder neck incision has not been adopted yet as a standard sort of, just as a note, the EAU suggests that a delayed ablation after suprapubic diversion is done in the case of a very small urethral caliber that won't allow a pediatric cystoscope. In terms of bladder diversion or vesicostomy, the role is generally done when patients either too ill to go valve ablation or when they are too small and cannot accommodate a pediatric endoscope, or in the case where there's high PVRs, persistently elevated serum creatinine, or recurrent UTIs, despite evidence of adequate valve ablation. It's generally done either via a suprapubic sort of percutaneous tube or formal cutaneous vesicostomy, and it has the advantages of reducing bladder storage pressures, improving or stabilizing the upper urinary tract, and relatively rapidly, albeit temporarily, improving the renal function. Disadvantages is fear that it might lead to decreased bladder compliance or decreased capacity. Doesn't seem to benefit, to have any long-term benefits in terms of end-stage renal disease. And obviously it would require a further anesthetic and reconstruction. Although the argument regarding that the vesicostomy defunctionalizes the bladder has largely been refuted, sort of the literature, as well as the Campbell cites that a properly created vesicostom will still allow bladder filling and urine to be expulsed through the stoma, even though it's at a reduced leak point pressure. Upper urinary tract diversion is generally done when there's ongoing deterioration of the upper tract renal function despite adequate bladder drainage. And the rationale behind this is that it protects the upper tracts from a tortuous intramural ureter passing through a thickened valve-affected bladder. The fear again is possible defunctioning of the bladder with impairment in compliance and contractility. But certain techniques have also sort of refuted those claims by mitigating the concern of such as a loop diversion or a sober on T diversion. So just two questions regarding urinary diversion that I found quite interesting. The one is vesicostomy versus a supravesical diversion, which one to choose. And literature seems to suggest that if one is to choose, the vesicostomy is probably preferable as it is better at preserving bladder function, and it is also associated with a lower bladder augmentation requirement as compared to supravesical diversion. Does it have an effect on the renal function and the progression to end-stage renal disease? Well, the short answer is no, it merely delays it. But I think this shouldn't be underestimated, as dialysis in small infants and children generally has a higher mortality, and renal transplantation is technically easier and has been shown to have better outcomes in older children. The last sort of section of the management of these children is long-term management, which includes bladder management and follow-up. They should really be started early on a sort of a timed or double void regimen to try and prevent the sort of valve bladder changes. Antibiotic prophylaxis is generally recommended for the first few months of life. And in the case where there's a concurrent phimosis, a circumcision might reduce the risk of a UTI that's already higher in boys with valves. It might reduce that risk by about 80 to 90%. Early initiation on anticholinergics or oxybutynin might increase bladder compliance and capacity and improve hydronephrosis. And alpha blockers can assist with helping keeping the post-voyage residual at a minimum in cases of sphincter hypertonicity or bladder neck hypertrophy. However, this might still, even though those measures are initiated, there might be ongoing renal function deterioration, even though there isn't a fixed obstruction due to polyuria and reduced bladder sensation, often because of overdescension at night, and then might need to institute nocturnal bladder drainage, either via indwelling catheter or nighttime sort of double voiding regime, as this has been shown to decrease bladder pressures, give the bladder a bit of a period of rest, and essentially improve bladder dynamics and upper tract outcomes. And it slowly seemed to be a part of the standard of care for these boys. Clean intermittent catheterization might be necessary if there's ongoing high PVRs in the day, despite earlier medical and sort of voiding management. Although metrophin of appendicovesicostomy might be required in the cases of sensate urethras or those with elevated bladder necks that might make catheterization difficult. Just a short word on bladder or augmentation cystoplasty. In this era, it seems to be rarely utilized due to a better understanding of the bladder dysfunction and the sort of valve bladder, as well as the measures previously mentioned. However, it might be necessary when faced with a small capacity, high pressure, thick-walled bladder that continues with continued upper tract dysfunction, despite all the above measured measures. As mentioned, the risk for end-stage renal disease is quite high, so it's very useful looking at prognostic factors to be able to prognosticate and counsel family in terms of renal outcomes. And a sort of a nadir serum creatinine done at 1 year seems to be more accurate than 1 month, and that's sort of the preferred prognostic factor. where creatinine more than 1.2 milligrams per deciliter, or sort of plus minus 106, more than 106 micromoles per liter, confers to the highest risk of poor renal outcomes. Signs of renal dysplasia on ultrasonography is also a bad sign. And the age of presentation, I think, is unclear and is not, can't really be used as a prognostic factor. And initially, it was thought that the later a boy presents, the better the prognosis. The data seems to have, or the literature seems to have mixed results with regards to that. Favorable prognostic factors is achievement of daytime continence by the age of 5, and certain or the presence of certain pop-off mechanisms. Just to sort of end off, long-term follow-up is necessary and extremely important, as even when the anatomical bladder outlet obstruction has been addressed, there can be ongoing upper tract dysfunction, renal failure, and incontinence due to the involvement and bladder changes, as mentioned earlier. Nephrological, urological, psychological, so essentially a multidisciplinary team is important. And unfortunately, there are no standard guidelines regarding this, but it will probably be in the form of annual creatinine, ultrasonography, and urodynamic studies is quite important as well. As clinical examination and patient questionnaires might underestimate the degree of bladder dysfunction as these boys age. There doesn't seem to be a difference in erectile dysfunction or fertility long-term and compared to the general population, but the chronicity of the bladder dysfunction, the risks of UTIs, and the sort of effect in the sequelae of renal dysfunction will have a significant impact in the quality of life. And the as there in the bottom suggest lifelong monitoring in these patients. So just to conclude and to end off, urethral valves are cited as the most common cause of bladder outlet obstruction in the pediatric population. Even though they've been studied for a very long time, there still seems to be an ongoing debate regarding their origin and embryology. And the presentation varies according to the age of presentation and probably according to the degree of the embryological abnormality. Management is multimodal and multidisciplinary. Antenatal intervention can be considered in select cases, but the data is, in the literature is rather scanty still. And even though valve ablation is the easy to perform procedure, it is only the beginning, as these boys require long-term follow-up and bladder management to try and mitigate and avoid end-stage renal failure and the transplant and dialysis complications that come with it. Thank you very much.
Yeah, thanks a lot, Bernard, for an extensive overview of COPAM. I think you really touched on a lot of that. Yeah, thanks a lot for the extensive overview of the topic. I don't know if there's any questions on the floor. I wanted to ask about follow-up. I think you touched on that very well on your recent slides. Anyone with questions on the floor or on the platform? Prof. Lazarus, I see you are muted there. Also interested to hear how you surveil these patients in terms of follow-up scopes, or any other comments that you may have.
Yes, can you hear me okay?
Yeah, we can hear you, Prof.
Yes, hi Bernard, just real congratulations. That was such a superb talk, very impressive, well done. Just two brief comments. Sam's comment about follow-up, I think, is key. Roughly a third of the patients on the renal replacement program at Red Cross have valves as their primary diagnosis. And so many of these kids are going to run into trouble at some point, so clearly follow-up is crucial. And your ultrasound, baseline, urodynamic studies, involvement of the pediatric nephrologist, all key. And we become more aggressive in terms of managing the valve bladder syndrome, in terms of that kind of surveillance, but also managing it a bit like a neuropathic bladder. In many ways, it behaves the same way. And so aggressive management with anticholinergics, CIC early on, potentially augmentation in some of the kids. So aggressive management, a bit like you would for a neuropathic bladder. You also mentioned the importance of a repeat scope. We've moved away from doing an MCUG as follow-up to assess whether we've been successful. In much of medicine, less is more, but in terms of valves, my belief is very much that more is required. An aggressive TUR of the valve is important to ensure that at the end of the procedure, when you push on the lower abdomen, you get an easy low pressure Craig maneuver, and definitely bring them back at 6 weeks to see. If at that time the creatinine hasn't budged, the hydronephrosis remains severe, we would then do a repeat ablation plus a bladder neck incision. And there's, to my way of thinking, good evidence from a good randomized trial from Iran of all places, where they followed up kids who'd had a BNI versus those who didn't. And urodynamically, those who had a BNI did better. So aggressive TUR for these kids, I believe, is appropriate.
Thanks for that comment, Prof. I think in the absence of questions and time, once again, thanks a lot, Bernard, for an excellent talk. We'll move over to your colleague, Dr. Gautam,
Yes.
on the approach to antenatal heart nephrosis.
You can present.